Bombay Ophthalmology Association team to this second edition, or take two as we are calling it, of the eye crash investigation. And we have some very interesting presentations and talks lined up on a topic that all of us encounter almost on a very regular basis. I would like to welcome our President, Dr. Himanshu Mehta, Dr. Lahane, to this meeting. And may I request Himanshu sir to please initiate proceedings.
Good evening, Manish. Thank you so much for your sweet introduction. It's a great pleasure to have a meeting like this organized. Thank you for doing the same, Manish. Practical problems are the most important that we really need to sort out. Day to day, we may show in presentations and in conferences a lot of things, but here we will pause, think, reconsider, adapt, understand, modify our steps, and proceed. The most important part in life is to learn from our own experience and from other people's experience. It's always nice to reflect back and see what can be done, what went wrong, how could we avoid it, what is the next step to be taken in case we land into it. So the biggest thing that we have is the Lakshman Rekha, called the posterior capsule, for the anterior segment surgeon. And it is the thin capsule for which we have a lovely microscope. All the techniques of surgery that we learn is to see that we stay within our Lakshman Rekha. The moment we cross that for accidental reasons or ignorance, we land into trouble. And that's where Ravan comes into the picture. And you really don't want to look at the vitreous. But just in case, if it does, what to do, how to tackle. That thin line of demarcation between a hero and a zero is that boundary line. You know, if a Yuvraj hits a 6, it goes for a 6, you are a hero. You've taken all your chances. And if you're caught before in the boundary line, then you are a 0. This is exactly what your PCO is. Your posterior capsule is only one, PCR. And the moment you touch it, you neglect it, you don't understand the zonules, don't understand the structures. All of them are waiting to pounce on you. So this is session 1 on PCR, friends. We're going to have more sessions because this is the most dreaded thing every ophthalmologist really fears. During his residency, in his fellowship, and all our lives, we struggle and struggle to see that we don't land up into these situations. And to help us understand various problems, we have our own people who will be telling us what to do, what not to do, what is right, what is not right. We have our own fellow member, Dr. Ronak Solanki, who will be talking to us today. And he'll be the opening batsman to tell us what happened in his case, where was the trouble, what did he do, what else can be done, and how can we salvage the situation that we are in. Ronak has been trained in LVPI. He has been with Hubli also at MM Joshi. He has been at Arvind. He has done a short stint at Greece on refractory. It's a pleasure to have him here to see that what was his complication, what did he do. Over to you, Ronak. Thanks for being with us.
Good evening. Thank you, Himanshu. So at the outset, I would like to thank DOA for this opportunity. I'll just present the case directly. There's no PowerPoint slides. We'll pause in between whenever needed for some questions. So there's a voiceover, if you can hear the voice.
So this is a case of a 70-year-old high myopia planned for a toric monofocal lens. Case has started routinely with the continuous curvilinear capsular axis, and further nucleus management is uneventful. Adequate sized CCC is made. Stop and chop technique is used for phacoemulsification. I used 2 dialers to split the pieces because of the deep AC. The last piece of the phacoemulsification is carried out using a single instrument to prevent collapse of the anterior chamber. As you can see, there is a cortex removal that is going to start, and this is where the complication happens. You notice a posterior zonular dialysis in isolation along with an equatorial PCR due to the rip and an intact round antral lens capsule. Let's have a look at it in slow motion.
This is where I've pressed the reflux.
So I'm now trying to remove the cortex matter because the anterior chamber is maintained. You can also use viscoelastics to fill the bag. So in trying to catch the cortical leaflet, the
Can you stop,
posterior
Ronak?
capsule
Can you pause, Ronak?
Yes, sir.
I would like to ask the panelists that you get into a situation like this. What would you do at this point in time? Yes, Ronak, just pause it there.
Shail, you want to go?
Yeah. So the first thing that I would have probably thought of doing is whenever something doesn't seem right, just take a pause. And what I generally like to do is keep the irrigation on, remove the aspiration and have a look with the irrigation on what is actually going on. And still, if I'm not able to figure out what is going on, what I would like to do is just with my left hand, inject a dispersive viscoelastic over the area where, I suspect something might not be correct. And then I withdraw the irrigation and then try and reassess what needs to be done.
Yeah, in this situation, I'm not sure whether it is just the posterior zonular dialysis or the equatorial tear. But looking at an intact rhexis margin and a very nice anterior capsule, it goes more in the favor of probably an equatorial tear, which is extending now. Now, actually, this situation is quite confusing. In the first glance, we don't know whether we're just an equatorial PC is folding here, actually. Do we have a posterior zonular dehiscence or an equatorial tear? But once, after a couple of seconds, probably it becomes a little bit more clear. And I would request Ronak to correct me if I'm wrong. I think it is more of an equatorial PC tear which happened here. You can just rewind and play it in the first shot. Rewind and play the first shot, I think.
Let's have dialysis in isolation.
Yeah, at this point, you can see it is just the equatorial posterior capsule is folded. Now, at this stage, it's very difficult to see whether we also have a equatorial posterior capsular tear also involved here. But looking at the very healthy and non-distorted rim of the anterocapsular margin and the anterocapsule extending up to the equator, it looks like probably an equatorial PC tear is also there. That is what would be intended.
Initially, I thought it would just be a PC folding, but then the anterior capsule was so much intact, it seemed very unreasonable for the whole bag to come ahead and just the rim to be intact.
Yeah.
So it's a combination of the tear along with the weak zonules, because I just caught the leaflet of the cortex. It's not like it's a blind thing where I've caught the equator and pulled it ahead. If you see, it's a bit split.
So I would pause at this point. Not too much of movement. There is not much time to think. Don't come out. Do not remove your bimanual at this point in time for sure. Don't let the chamber flatten. Whatever chance you have to salvage will be there only if you stay like a statue at this point in time. And as Shail said, think what has gone wrong. If you have a foot pedal and you can just do a back flush, don't pull too much at this point in time. Let the cortex float back. The capsule will go back. Reduce the flow, take the bottle down.
Yeah, so that's exactly what I did not remove my probe. I'll just play it once. So at this point, I press reflux and let it go, and I was observing.
Right.
I'm not trying to remove the cortex matter because the anterior chamber is maintained. Could have also used viscoelastics to fill the bag. So in trying to catch the cortical leaflet, the entire posterior capsule gets ripped apart.
put viscoelastic and I've just tried to remove whatever cortex I can before it.
We fill the chamber with viscoelastics and proceed towards an anterior vitrectomy. I give a lot of importance to staining the vitreous with triamcinolone acetate for better visualization and making the job easy and to detect those fine strands which are left sometimes.
Ronak, stop. Ronak, stop. Ronak, stop.
Yeah.
I would ask the panelist, would you have put in a CTR before you do anything, before you look at the vitreous?
So, sir, three things that maybe we can learn from this case. One is when you think things are not going as per your plan, lower your parameters. So the first thing I would have done is reduce my flow rate from whatever it was to as low as possible, so that even if I catch something like you caught the capsule, it wouldn't completely come before I can react to it. So one is, in such a situation, I would lower the flow rate to the minimum possible, 6 flow rate per 6 cc per minute. And to me, honestly, on the video, it looks like the zonules also may have come off at the first time. So my first reaction would have been inject dispersive viscoelastic, reassess, fill it with cohesive, and put a CTR before I would have proceeded with further
Correct.
removal.
Correct. So I would say that putting a CTR would help you tremendously. The zonules would not be that weak. There'll be not too much of fluctuation. Deepak, what would you say?
But there is a suspicion of a peripheral PC tear as well here. There's no continuity because there is posterior capsule is not intact in the peripheral part. So, and it is very much evident, or it became it get exaggerated when the second time the posterior capsule and the bag got in contact with the aspiration probe. That time the entire bag shifted. That time I thought there is also a posterior equatorial tear there. So with an equatorial tear, CTR wouldn't work.
So at this stage, I thought I could put a dispersive, fill the bag and try a CTR. But when the next step, the PC came up, it was evident that there was a equatorial tear and there was no place for a CTR then. So then we proceeded with the vitrectomy.
And detect this fine. Start by clearing off the anterior vitreous, which is already prolapsed. Just a little bit of vitrectomy and then turn the bevel down to prevent more and more vitreous prolapse during cutting by facing it bevel down. The triamcinolone helps a lot. After thorough vitrectomy, the remaining cortex is removed in the IA cut mode. Care is to be taken to prevent damage to the anterior lens capsule, which is going to be useful for an optic capture when a three-piece lens is placed. Pilocarpine was used and the wound was sutured, and the eye was planned for a secondary IOL on the next day due to the unavailability of the hours. So we have planned a separate incision at 60 degrees because of the steep pixels at that position and a toric lens which could not be implanted due to the posterior capsular rupture and the tear. So this way, at least the 0.75 pre-existing astigmatism was reduced to around 0.5 on post-op by using a 3.2, 3.5 millimeter incision to insert the three-piece IOL. And centered on its axis. job is not over yet. And we will now plan for an optic capture of the 3-piece lens for long-term stability and centration without any tilt. So reverse optic capture is planned by tucking the optic part under the anterior lens capsule. Mobilization of the anterior margin is seen, which indicates a proper reverse optic capture of the lens. So on post-op, the patient had a best corrected and uncorrected visual FT of 6.9. So a few take-home points. In high myopia cases, always anticipate intraoperative zonal weakness, avoid anterior chamber fluctuations and pulling at the prolapsed vitreous to prevent breaks in the retina. Anterior vitrectomy using triamcinolone acetate is very useful. Reverse optic capture ensures long-term stability of the IOL and prevents other complications and side effects. Thank you.
Thank you, Ronak. That was a nice presentation. Very well done, very well managed. No question about it. But I like the bold decision. Identifying the zonular tear and or a posterior capsular dehiscence is the first earliest step. The later you do it, the more the trouble that we can land into. Second, well managed with the triamcinolone. We'll have Shail to counter that also. Shail, we would love to see that video of yours where you go in from behind for the posterior vitrectomy. But it's nice to listen that, yes, you can still handle it because most anterior segment surgeons are not quite used to going from pars plana area. So you could handle it. And you did not inject too much of triamcinolone, it only in that vitreous area. So not much was seen in the vitreous later. Second most important bold decision was to abort that day and not put the lens on the same day. I guess possibly because you did not have a lens standby. Is that the reason?
It was a very high myop, so the power was around 9 and 10. So I did not have a 3-piece standby of that range. I usually have the normal ranges from 16 to 24, but I did not have the lower one.
It's perfectly fine. So one more thing is eat up your ego. Yeah. And if you have to do it on the next day, there is no harm. Patient interest, nobody will remember that you waited for a day. So for doing it on the next day or a third day when your nerves are cool. Because to do an optic capture when your hands are shaking after a vitreous loss at the same time would be a difficult job. So well appreciated what you did. Any tell Dr. Lane or
Ronak, excellent management. Just a slight clarification.
Yeah.
What you described is the conventional optic capture. When we say reverse optic capture, it typically means haptics in the bag and optics above the capsule.
I'm sorry, it was
That's for yeah. But excellent.
Yeah.
I think Ronak, you managed very well.
Thank you.
And definitely CTR was not possible in such situations. And what you do, optic capture was also good. It was very good learning and teaching both video. Thank you very much.
Thank you.
Thank you. Deepak, would you like to have any?
No, sir. I think he did manage very well. I think that the best part which I liked was he acknowledged the fact, okay, fine, no problem. I'll put the lens the next day. That was the best part which I liked. Okay, because it's unlikely that we can have a backup lens for such a lens, but it's also a lesson that probably in such cases it's better worthwhile to have a backup lens whenever it's not there in our routine power list. So that's a lesson. Probably I would now arrange for a high myopic backup lens as well. That's a lesson which I learned. You never know when it goes wrong.
I usually counsel all the high myopes if they're in the range of 29-30 axial, and I always tell them there's a chance of any intraop weakness. The bag might not support your lens. We might have to do it on the next. This patient also, he was a very known patient. So I've already explained him and he was absolutely fine with it. He's like, yeah, you have already told me before. So he was not fussed about it. So I think counsel also plays an important role, even in routine cases.
Yeah. So at the back of our mind, that pressure, that what will I tell the patient is not a great idea. Taking a bold decision, as Deepak said, and I totally agree, is a very important thing. Now comes the question that I would like to ask the panelists. In high myopes, almost every time, would you like to put a CTR? Because you do expect some amount of zonular weaknesses. Would the panel agree that should we be putting a CTR primarily or should we not be?
So I would generally not do it unless unless I find something abnormal. So as a routine, as a rule, I would not do any extra intervention which is not required.
Deepak?
But in cases of somehow in toric lenses, high myopes with toric lenses, somehow I find that I prefer to use the CTRs, larger CTRs. The reason for that would be the posterior capsule is slightly pushed in forward. It is stretched. It has got a better apposition with the optics. So the lens stability is slightly better. That's what I feel. But there has been a counter argument that, you're expanding the bag. How is it going to stabilize the lens? But in my experience, the stickiness, the approximation of the posterior surface of the lens with the posterior capsule is much more higher. So if I'm planning a toric lens, I prefer to use a 12 to 14 mm CTR when a toric lens is planned. That is my. Yes.
Okay, now that's question on why 12 and why 14, and when 12 and when 14.
Most of these myopes who have got a horizontal wide to wide diameter which is beyond 12.3 or something, which we know. So those we have got dealing with very big bags. So the conventional CTR, I don't think it is really going to stretch and pull up the posterior capsule. Those are situations where the larger CTR is definitely going to help. So 12 and 14. The convention is the 11 and 13 what is available. The bigger one is the 12 and 14. So when we know that the horizontal wide to wide is bigger, in those situations, I definitely prefer to go in with the bigger CTRs.
I think that's a very valid thing because, at that time, again, to get a CTR standby, when you don't have a lens, you have to have a CTR standby and your vitrectomy standby, which could be there. Dr. Lane, sir, would you like to give any comments, sir?
Deepak said is very true. But for every patient, we should not go for the CTR. And in the pathological myopia, sometimes you can see the, if required, and like toric lenses. I also always think that for the toric lenses, we should go for the CTR. When it is a myopia is, I can say more than 10 or more than 12. In such situation, we can use the CTR that will definitely stabilize the lens. But for stabilization of the bag, CTR will not work much. And for routine cases, I am not using.
Thank you. Thank you so much. Manish, would you like to have any?
Sir, I was wondering, when we are doing the rexes, we do get an idea. Now, in this case, the rexes was pretty easy to do. So, I mean, if you get a feel that the zonules are strong enough, you wouldn't really want to put a CTR in every case. It's only when you get an idea that there is some weakness that you would want to put. And the other thing was that, I was also wondering whether when you're distending the bag, in case of a toric lens, how it would help. That was the other query. I think Dr. Shail also mentioned that.
Deepak, would you like to say that?
Yeah, my argument for that is when the equator is stretched, the posterior capsule is pushed forward. It is pushed more anteriorly. So there is a better chance of the lens sticking onto the posterior capsule. So that's the reason why I prefer to use a CTR in these where I want a stabilization. Of course, we need to have a well-centered 5 mm axis. Along with that, if you have something like the posterior capsule is pushed forward, stickiness, it sticks to the bag, posterior capsule much more earlier. That ensures the lens or minimizes the chance of the lens rotation. That has been my philosophy.
Great. Last question, Ronak. Is it mandatory to have an optic capture or it was a 3-piece lens? You could very easily leave it in the sulcus.
Yeah, but I preferred it for long-term stability and better. Otherwise, what would happen if there is one tilt or progressively over years, there would be some cylinders induced. And sometimes you have those UGH syndromes and all that. If the, if there is a mid-periphery billowing of the iris and pigment release is there. So he was already a POAG patient, as I mentioned in the history. So I thought I would rather just have it in a normal anatomical position under the anti-lens capsule.
Yeah, thanks. Just wanted the logic. But if you leave it like good old days when we were doing it, when can opener technique was done, and we used to put a lens in the sulcus without any questions, hardly any UGH. So yes, it's nice to have an optic capture, but you could very well escape without an optic capture also. Thanks, Ronak, for a lovely presentation, good discussion. We have Dr. Shail Vasavada. He needs no introduction. One of our very, very dear friend. And believe me, friends, I must tell you, all three of them, one phone call agreed. And I must appreciate that. Their timings with family, with dinner. Shail, at the outset, I would like to thank you and Deepak for acknowledging and being on the panel and sharing your knowledge. Shail is a prolific surgeon based out of Ahmedabad. He is a great national speaker and always been invited everywhere. He has very clear understanding about the subject, and his videos are very self-revealing. We will see what to do at every step. There is a logic. There is calm, cool, like the way he is, and he presents himself as a surgeon. I've seen him as a very calm, cool person, and that's what is required in the time of crisis, to cool down your nerves, breathe well, and just do what next has to be done. Shail, over to you. Thanks so much for being with us.
Thank you so much, sir, for having me. And I'll be sharing a series of cases where from each case I learned something, I applied it in the next case, and something new happened. So you keep learning, as they always say. So this was a 30-year-old male, bilateral posterior polar cataract and glare while night driving. So we counseled him, and we prefer to do the flax in such situations. These are the cylindrical lens division patterns, which means that the lens, this is a form of, multiple hydro delineation, you can say, what we described as femto delineation. So without injecting any fluid, we remove each epinucleus from the support of the other. And being a polar, we want to try and make sure that there is less turbulence inside the chamber. So I'm using a moderately low IOP of 30 and a flow rate of 20, which is my standard. I generally never go beyond a flow rate of 20. Therefore, most of the times it happens very slowly. At this point here, you are not trying to remove this epinuclear plate. The aim here is to just detach this epinuclear plate from the fornices. So what that does is it creates a communication now between the anterior and the posterior compartment. So now small amounts of fluid will start trickling down. So that means that if in an elderly patient, if you have a very thick epinucleus remaining, after this point of time, you can even do a hydrodissection without the fear of causing a sudden rise in the intralenticular pressure, because you have created an open area here through which the fluid can pass. Like sir mentioned, always make sure that the chamber never collapses. So inject dispersive viscoelastic before making sure that this probe is removed. And because this was a very young patient, this epinucleus was soft. Even if you are not normally doing bimanual irrigation aspiration, I think posterior polar is something where I would strongly recommend, so that the main valve of the incision is not disturbed. And fortunately, things have gone off well. The polar part has been removed, and centered nice rexis planned for a multifocal toric IOL. Everything has gone off perfectly. And this is when sometimes you get over and above yourself. So I thought this is a young patient. I'm doing a multifocal toric, and these fibers don't seem to be the typical polar which are stuck around the disc. So let me just, with a very low vacuum and a low flow rate of 6, let me just peel off these fibers so that he also gets a clear visual axis. And that's something that was already taught, but I learned it the hard way, that never touch the capsule of a posterior polar cataract. So I started with a nice intact capsular bag and a strong anterior capsular axis, and I've created iatrogenically this defect in the posterior capsule. Now, once having done that, the aim is now to still somehow, if you can, go ahead with plan A, that is in the bag IOL. So for that, if you notice, I've kept the irrigation on inside the chamber. I've withdrawn my aspiration probe. And now first I'm injecting dispersive viscoelastic. And here dispersive viscoelastic is mandatory, because that means dispersive will stay there. Cohesive can immediately come out as a bolus. So dispersive will tamponade that area of the PCR that has occurred. And now I'm injecting cohesive viscoelastic, because I want to see if I can still convert this posterior capsular tear into a strong posterior capsular rexis margin. Remember, this patient is under topical anesthesia, so you can see some eye movements that are occurring. And from one end, I've been able to convert this into a strong margin. You need to convert the edges on both sides into a strong margin, because while injecting the IOL, if the margins are not strong, they can immediately split right up to the equator and your IOL's stability will be compromised. So I'm making sure I'm converting from one end completely. And once that is done, I'll approach it from the other side. So here again, a take-home message is to have appropriate micro instrumentation, micro incision rhexis forceps. So I finally managed to convert it into a strong PCCC from both sides. So now this will act like as if this was an ACCC through which I'm putting an IOL. And since I have a strong capsular rhexis margin in the posterior capsule, I can go ahead with my plan of going ahead with in the bag IOL implantation of this single piece multifocal toric. It helps if you have if the IOL unfolds slowly, and therefore cohesive viscoelastic is mandatory when you are injecting toric IOLs, particularly in such situation with an open capsule. And I'm making sure that I align it just about at its place from there. Obviously, this is not the case where I'm going to go behind the IOL to remove viscoelastic. I'll probably give mannitol to this patient post-operatively. And this is how the patient looked at the end of surgery on table, ACCC, PCCC, and in the bag IOL toric. And this is the patient almost 6 months now. And notice the IOL has not rotated at all. So if you have a strong PCCC, you don't need to worry about the stability, even if it is a toric IOL, and monitor the retina, because these are the eyes which are not only likely to have macular edema, but also peripheral retinal lesions. And always have your retinal colleague examine him in the post-operative period for peripheral examination. And this is how the patient looks now 1 year post-operatively, absolutely stable, centered multifocal toric in the bag. So the lesson from the first case was, never touch the posterior capsule in a posterior polar cataract, however much you may think you have the best machines or the best foot pedal control, because these capsules are extremely fragile and can give way at any point of time. Coming to this second case, another posterior.
We'll pause
yeah,
here.
Sure, sir.
Yeah. Posterior capsule, posterior polar cataract, big topic by itself. We're going to take up that later. But as you said rightly, we can have a preoperative rent in the capsule. Anytime we are removing the cortex, we can have it. And I have seen your case where while closing the chamber at the end, a little more fluid and the posterior capsule can give way. So the posterior capsule has a mind of its own here. So would you give mannitol from the outset? Would you give a peribulbar? Would you like to see that the pressure is down always? Because with the idea that most often than not, the capsule is going to misbehave.
So, sir, generally, if it for most of these patients are young and generally quite deep chambers, so I would not give mannitol preoperatively or consider peribulbar unless it's an extremely anxious person, because majority of these are softish cataracts. So in that sense, we are not so concerned about a drop nucleus or that kind of grave complication happening. Of course, if it's say grade 3 nuclear sclerosis with a posterior polar in a slightly more elderly person, or I would consider giving a peribulbar. But in a routine standard soft posterior polar, I would still go ahead normally like I would do with topical anesthesia, and no additional preoperative measures to be taken.
Deepak, anything that you would like to say?
No, I would agree with you, sir. I don't think preoperative mannitol as such has any role in preventing the posterior capsule ruptures in these patients. However, in young patients, most of the young patients are very anxious and also a little more sensitive to pain compared to the older people, because posterior polar cataracts, we operate them relatively younger. Maybe in intraoperatively, if I suspect that the patient is a little bit sensitive, then I would give a posterior subtenance then and there just to make him more comfortable. But I wouldn't consider giving any IV mannitol or anything. But definitely, depending upon the individual, his anxiety levels and his sensitivity to pain, I would consider maybe some enhancement of local anesthesia.
So, Dr.
That's an excellent point that these are the cases where I think the role of the medical anesthetist is so important. And they have these so many nice modern medicines and the cocktail of midazolam, fentanyl, and things. They work so beautifully when they give IV through the cannula. It's almost like they behave almost like peribulbar.
Dr. Lane sir, would you like to say anything?
I think what Shail saying is very true. So this combination of sedation definitely works, and the mannitol or other things in cases where you want to reduce the pressure of the vitreous really doesn't work, because here the capsule itself is a thinner. Though it is seen intact, the capsule is thinner. So smallest, you can say the pores, what we are doing, that can cause the tear in the posterior capsule. So I think what Shail managed is perfectly, he has managed the case.
Yes, Shail. Shail, go ahead, your second case. Thanks.
So another similar case. Now this time, I knew that we should not touch the capsule of this patient who is suspected to be a polar with a plaque, and once again performing the cylindrical lens division pattern. And fortunately, everything has gone off well. And I have smartly left behind this plaque that if it bothers him later on, bothers the patient later on, I'll do a YAG capsulotomy. And now, definitely, I don't think there's anything that can go wrong in this case anymore. So I'm going ahead with IOL implantation. And if you notice here, the cartridge actually, if I go back and keep looking at the cartridge which is locked at this point in the wounds of the incision actually just comes off, and that was probably not the wisest decision then to just still try and force it without disengaging it and making sure that I re-engage it properly. So the first learning lesson here was that if you feel that the IOL or the cartridge or something is not moving as smoothly as you think it should, just withdraw it before making it an ego that you have to inject it since you have loaded the lens and locked the cartridge inside. So now I'm in a terrible situation where supposed posterior polar, which I prevented from rupturing, didn't touch the capsule. I've got a lens stuck in and it has, sort of hobnobbed on the posterior capsule. I'm still not sure whether it has ruptured the capsule or not. And I'm in a little bit of a panic mode that let me just slightly enlarge this incision so that this sort of releases and I can at least make sure that this lens goes in a little bit. But while doing that, notice how the eyeball has shifted. And this maneuvering has finally revealed the things that have occurred here. So this, I have a PCR. If you can see this dome shape of this PCR that has occurred with the capsule. This is the torn edge of the capsule, and this is the irregular margin from which it is detached. So now I'm in a soup. I have a single piece IOL inside the eye with one haptic trailing outside, and the posterior capsule has ruptured. So again, I thought, let me go ahead and at least try and create some sort of semblance or try and see if this posterior capsule is still somewhere salvageable or has it gone completely up to the equator. So from one edge, I could find that here I've had a rounded edge and I've been able to sort of pull out at least from one side. So I have a rounded edge on one side, but I'm still not sure below this haptic what is happening. So the first thing that I want to do is I want this eye to remain closed and stable because I know that I must have disturbed vitreous during all of these maneuvers. So I'm making sure that I suture this wound before I do anything else. And our preferred way of handling or tackling the vitreous is through the pars plana approach. And to insert a trocar in an open eye is little challenging. So either you have fluid coming in or you tightly suture the wounds in such a way that the eyeball pressure is firm enough that you can insert the trocar. So I've inserted the trocar. I'm still trying to find out if I am just removing this flap from the other side, so I have a rounded margin. And now I'm injecting triamcinolone, which I expect it to be there. And if you notice here, the advantage of pars plana, that through this entire opening, you'll see this entire chunk of vitreous getting drained and sucked in without any turbulence being caused in this zone of the PCR that has occurred. So there is no flutter of the capsule occurring. There is no enlargement of the PCR that is already pre-existing here. And now I've been able to cut or sever the connection between this anterior strand and the posterior strand. Keep looking here and you'll slowly see this come up and float freely into the anterior chamber, which means that the connection that it has with the posterior part or the posterior body of the vitreous is lost. So if you can notice here, it's
Just
freely
pause. Shail, pause. That is the area where you've just cut off. You cut off from the posterior part. That is what you are trying to show, right?
Yes, right. So once that is done, I'm still doing vitrectomy in and around the area of the PCR to make sure that the rest of the thing is clear, and whatever is stuck in the incision now is free from its posterior compartment. And always try and make sure that you not only remove the whatever vitreous is present, but somewhere even around the posterior capsular tear, so that there is as symmetrical removal of vitreous as much as possible. Now having done that, now I still have now an intact ACCC. I've managed to convert that PCR into a PCCC from both sides. And this is what I wanted to highlight, that when you're doing a limbal vitrectomy, you tend to drag on a much larger chunk of the vitreous. So the vitreous keeps prolapsing and the tear often keeps enlarging. Compare that to the pars plana approach, where you can actually, make sure that this gets drained in properly, so that the chances of PCR extension are much less. I want to make sure that I visualize everything. Now I don't want to be heroic in any which ways. So at this point, again, I'm putting iris retractors, because this is the area which I've converted into a PCCC. So I want to make sure that I see it properly, that it is a continuous, nice, rounded edges on all sides before I go ahead and consider implanting this IOL in the bag. And here I'm doing, making sure with my two instruments that I'm pushing the optic haptic junction down rather than rotating it much. Single pieces are difficult to rotate. So I'm making sure that I make the optic haptic junction and push it behind the anterior capsular axis. And I'm making sure that this has completely been achieved by using these Y hooks and V hooks to make sure that the IOL is in the bag. Always at the end, also make sure that there is no vitreous disturbance that has occurred throughout this manipulation of placing the IOL inside the bag, which fortunately there wasn't, and seal all the wounds before you withdraw your irrigation, so that the chamber doesn't shallow even at the last minute. And there's never you can never have too many sutures. So the moment you think one is enough, take two sutures. If you think two are enough, take three sutures. So don't be shy in taking sutures in such situations. And this is the patient 6 months post-operatively. You can notice this PCCC that is there. PCO has started developing in the rest of the other part of the capsule, and this is the scratch mark, which is quite away from the pupillary margin. So this was the second case that I wanted to share.
So, Shail, just a point at this point, what you have been showing. Nice case. One haptic bit out. So even without, your lens got stuck in the wound. So even without doing any manipulation inside, without touching the posterior capsule, the sheer impact of rotating the eyeball broke your capsule. Is that correct?
Sir, actually, I'll show you. It occurred with the jerky insertion. So if I'll just show this video, if you'll see, when it gets stuck, it sort of it stands up, and that's where it has probably occurred. If you see here now, I'm trying to push, and that's where it has, and it's in the same location that the tear was there. So I think that's the time when it has occurred, sir.
Okay. And the $1 million video is the red strand which you are showing of the advantages and disadvantages of doing an anterior vitrectomy and a posterior vitrectomy. I think that's a very well shown and a very well documented thing. that how the strands are coming in when you are, and more vitreous will keep coming in. And especially if you have the same port for irrigation and cutting, a lot of those vitrectomy cutters have an irrigation going simultaneously. It will irrigate the vitreous even further and more vitreous can be displaced. So you rather have a separate port from which the irrigation is going on. You can't have it simultaneously coming up. That's an important part, to disassociate the cutter from the fluid input. Deepak, anything that you'd like to share?
No, I think wonderfully managed and demonstrated cases. I think, one thing is, whenever these complications happen with most of us at the time when we think that the major part of the surgery is done. Now, Shail has done a wonderful removal of cataract. The posterior, he has taken care of everything. That is when we have a momentary lapse of concentration, and these silly things just happen. It happens with all of us. So I keep telling myself that picture abhi baki hai mere dost. Until you seal the wound in posterior polar cataracts, you never know. When you hydrate, then also you can rupture the posterior capsule. So keep telling yourself that one thing, that picture abhi baki hai mere dost. You never know when it surprises, it comes in. And usually whenever we feel that, okay, the toughest part of the surgery is taken care of, that is where the momentary lapse in concentration and something like these will happen. Second lesson is, avoiding not to using these dispersive like viscoat and cohevisc OVDs. They really have a great role whenever we land up in such situations. The simple fact is they maintain the chamber so well so that all your maneuvers can be done quite easily and comfortably. So the basic principle of surgery is you want to do everything in their normal anatomical position. So these are the OVDs which help us to maintain that. And that's what we need to learn. That's it.
Don't worry about the cost. Open up a new one.
Yeah, absolutely.
Just
Nothing is more costlier than vitreous or corneal endothelium.
Nothing. Your sleep. Don't worry about. Keep that cohevisc. What he said, Deepak. It's like a giant elevator, like a silicon oil sitting on the retina. It is there. The vitreous just gets pushed back. You feel very comfortable. And also, Deepak, if you leave behind a little cohevisc, the duovisc or cohevisc or whatever, does it give rise to pressures later?
Yeah, it does lead to pressure later. But again, as Shail had mentioned, that he is willing to manage it medically rather than risking it anyway. You can start on anti-glaucoma medications, use a little bit IV mannitol to maybe just decompress the vitreous along with this thing. So there are ways to deal with it. But definitely IOP has to be monitored.
Yeah, but it gets absorbed even though if it's a cohevisc, it just
gets absorbed. You can just a matter of time.
The take-home point is that very important. It could be methyl cellulose that you're using, HPMC that is, and or you're using duovisc or sodium hyaluronide. It takes time, but the body is very nice and surgeon-friendly. It does get absorbed.
Dr. Himanshu, just one question. I wanted to ask the panelists, a situation wherein a posterior polar or an otherwise cataract, a situation wherein the cartridge is malfunctioned and the lens is stuck in the wound. What would be the approach other than the one that Dr. Shail showed, which was to try and increase the wound? Would any one of you handle it any differently?
I would first have like to just, if it's 3/4 in and just 1/3 out or something similar, I would just use the forceps and try and push it in. Here, the reason why I was a little scared was I was back of my mind. I knew that this somersaulting of the IOL that had occurred must have led to a breach in the posterior capsule. And even if it hasn't, by my pushing maneuver, this thin capsule of a posterior polar may give way. But in a normal, I would just go in from the side port, fill the bag with cohesive viscoelastic and just try and push it with the forceps inside. And usually it works, at least if more than half of the IOL is inside.
In fact, one of the side effects of those, some of those, the upper lens and all, the hydrophilic lens, quite often the trailing haptic gets caught in between the inserter, the lens injector, and the tube. That, your blue tube and your inserter, it gets stuck there, and there is no way in which you can push it without tearing the lens. So that is even a more difficult situation we all have faced, right?
Yeah, sir. We work in municipal setups and we need to use those lenses. So I have faced that more than once.
Yeah. So
I think yeah, I will give one clue that whenever you are using the Alcon lenses or these hydrophobic lenses, these before that you don't keep these lenses in on OT where the temperature is very less. So they should be kept slightly at the room temperature, and this thing will not happen. So always bring the lens. You can say from outside the OT, keep it outside the OT, and then that will help you. So this is the AC cooling also gives such type of you can say the rigidity in the lens.
So just one point to share, like once when he identified that the cartridge was getting stuck, you could have just planned not doing a wound assisted and slightly enlarged, and because it was a polar cataract also, just to be more safe with more visco in the bag so that it delivers smoothly. It may take 2 minutes extra to remove the visco, but I think it's always worth it.
No, absolutely. I mean, I mean, this was overconfidence, like we said.
perfectly fine. Perfectly fine. We are just wonderful surgery. Shail, go ahead. We are running out of time. We can keep talking about all these things.
So,
It's
sir,
very
I can
interesting.
stop. I mean, I have a few more cases.
No.
but-
Please go ahead. We want to learn all that we can and juicy
So,
out of it.
another case now. I made sure that now the cartridge is inside. Second eye multifocal query polar query plaque. Everything has gone off well. And notice I'm using this relatively newer device at that time, the AutoCert, which means the foot pedal controlled IOL injector. And I was concerned. I was looking at the speed at which it is going, and it tilted a little bit, but it was filled with cohesive viscoelastic, so nothing untoward has happened. And I've made sure that it opens correctly inside the bag, and the second eye multifocal has gone on nicely inside the bag. What I didn't notice here is this at that point of time. So I didn't notice here this why this kind of blob is appearing at this point of time, but everything looks hunky-dory, and I'm going ahead with plan A, going behind the IOL to remove the viscoelastic. So this is irrigation behind the IOL. And this is aspiration in front, and look what has happened. So now another even worse situation than the previous case. Now I have a multifocal IOL inside the capsular bag, haptics inside, and I have a tear which is running up to the equator. And the first thing I'm thinking is that somehow I just push it and this remains stable, and I just pack it up and hope for the best. But obviously it's not going to center because there will be some presence of vitreous. I'm trying my best that, somehow it will center, but eventually you have to, bite the bullet. So injected triamcinolone, and obviously vitreous has prolapsed from that area because I very wisely went behind the IOL also to remove all the viscoelastic. That has made sure that the vitreous has come in front. So following again the same principles, that we want to drain the vitreous from the area from which it is coming, and keep noticing here through this entire PCR that is there, slowly but surely the entire vitreous right from the incision will get sucked in nicely into the probe, and that will also make sure that this tear that is there remains as it is without enlarging further. Always make sure here that your vitrectomy cutter is not very close to the intact posterior capsule. So keep it a little more vertical facing down. Use the highest possible cut rate that the machine has. And once the connection between the anterior and the posterior is severed, the one which is stuck in the incision, you can definitely go ahead and remove from the front. Again, removing vitreous not only from where it had come, but surrounding areas as well, making sure that adequate vitrectomy is done. And the IOL now appears quite centered as this stabilization has occurred due to the pars plana approach of vitrectomy removal. And now this patient has completed more than 3 years of follow-up with us. And this is the UBM of that same patient to show that there has been no tilt that has occurred due to this irregular capsule, and no aberrations also that have been induced by this. Always make sure that peripheral retinal evaluation is done by your retinal colleague in the early and in the post-operative period. And just the last couple of slides to show that what actually forms the support or the scaffold for the IOL. So it's not just the posterior capsule, but also the anterior intact or absent vitreous phase. And with limbal approach, although you can do a very good vitreous removal, there are unequal pockets usually of vitreous left behind in and around the area of the PCR because they are ergonomically very difficult to access. Compare that here to the pars plana, where not only the turbulence is less, but you have a much wider area or a much longer span where you can remove vitreous more symmetrically all around, leading to less chances of tilt even with an in the back IOL implantation. So these were the cases that I wanted to share, sir.
Thank you, Shail. Excellent presentation. I think great learning how to handle the vitreous at any given point of time. Thank you. Thank you for all the great input. You know, it's so important to cool your nerves and handle the vitreous, whether from anterior or from posterior. There are distinct advantages of going from behind. And my only request to a lot of younger colleagues is, it's not difficult to go at pars plana. Only thing is you're not used to it. You've not done it 50 times or 100 times. So if you do it on a regular basis, it's not very difficult. And with the trocar right now, it's very easy to get in. What you saw, Shail's technique also, that it's not difficult to get in 3.5 meter behind the limbus and the vitrectomy probe getting in. It's just that it'll make life a lot more easier for you than what you think otherwise. From anterior, yes, you can manage, but if you go from behind, it's a lot more easier. And a request would be, keep practicing in good cases and or times when you are at a different stage, or your vitrectomy colleagues. At least tell them and request them, if you can make the side ports, let them carry out a vitrectomy in a tough case. But the least you could do is attend the surgery at that time, create the side ports. The more you do that and the more you are ready to hold the cutter and get in, the easier it will be for you when you are in a tough time. I guess that's the take-home thing that I would say. Deepak, any words that you would like to say? Dr. Lahani, sir?
He has managed very well, but normally such thing happens with everyone. And posterior approach of vitrectomy is always better. But as we are anterior segment surgeon, we always think anteriorly, we never think posteriorly. But once you are having the habit of doing posterior vitrectomy, then definitely you will never come to the anterior side. So, and what he did is kept the lens, and after 3 years, his lens is stable. But I did in one engineer. It was in multifocal. I did vitrectomy, everything. Small tear was there. But after 2 years, that engineer came with the lens in the vitreous. And then it was a multifocal lens that time, restore. So then we did it, and then in the anterior capsule. But sometimes we don't know how this works for the longer time. But once it is working for 3 years, I think nothing to worry. He managed very well and very good teaching. And he has courage to show, okay, these are the things which is happening, and it happens with everybody. But nobody is, you can say, want to show it to the public. He feels I am the best surgeon. But I think Shail is a very good surgeon, and he has courage to show this. Also, he's a surgeon who can manage any type of case. So I'm really proud of Shail and doing very good surgery. Thank you, Shail.
Thank you, sir. Thank you so much, sir, for such.
And thanks, Shail, for your time and efforts. At this point, we call Dr. Deepak Megur. He needs no introduction. Some of those lovely, lovely videos that you've seen, high resolution, understanding the camera, the technique, the patience, deciphering everything to the minutest detail. You know, his understanding of the subject and the way he explains it to us, it's beautiful. His videos are really worth seeing. If you've not seen them on YouTube, they are there. He got recently the ASCRS Film Festival Award. And you will realize when you see it, yes, he absolutely deserves it. His point on corneal Descemet's detachment, or it could be the vitreous, and or putting a ring inside. Everything is worth looking at. Over to you, Deepak. Thanks for being with us.
Thank you, sir. Thank you for the lovely words. Thank you. I wanted to show a few posterior cataracts as well, but because already covered extensively, let me show you what or how to think when we have a PC tear with the nucleus still in the bag itself or in the eye. So we have until now we have seen all the cases where the PC tear has happened after the nucleus has been taken care of. So it's much more challenging to, first of all, diagnose a PC tear with the overlying nucleus still there. That itself is the greatest challenge. And second would be, once with the nucleus still there and with the PC tear, what are the options which we have? So I'll just show two cases in managing different
for
ways.
me to go ahead and crack it, I mean, introducing the two instruments, the Fakov probe and the chopper in my left hand, and I try to go in as deep as possible and then lateral separate, part applied these two bigger heminuclei into smaller fragments. Settings are changed to the chop mode. The tip is buried into the substance of the nucleus, and then the sharp chopper goes down vertically, and then there are lateral separation maneuvers. The chopping has to be done at multiple levels. So you keep on introducing the chopper at progressively deeper planes until eventually you see the crack in the posterior plate. The middle fragment is then taken out and then emulsified using continuous torsional energy. As the last fragment, the first heminuclei, is emulsified, there is an oval demarcation in the peripheral part of the posterior capsule which is staring at me. The oval ring demarcation was very well delineated and it was highly suspicious of a posterior capsular tear. Now, because it was very well delineated, I thought that even though it's a posterior capsular tear, there doesn't seem to be an anterior-hyaloid rupture as yet. And so I thought I'll continue with phacoemulsification, filled the bag with OVD and then rotated the second heminucleus, and then I'm proceeding to chop. As this heminucleus is divided, I decide to pull this fragment towards my left side so that I can visualize what has happened to the presumed posterior capsular tear. Well, I could clearly note that the size of the posterior capsular tear has enlarged. So now it was very clear to me that I was definitely dealing with a posterior capsular tear along with a possible vitreous disturbance as well. Now, since the phaco tip was still not obstructed and the flow was continuing, I thought the vitreous is still not present in the vicinity of the probe. So I continued to do phacoemulsification and remove this one loose fragment. Now we have got a big posterior capsular tear and a large fragment still in the bag. Now how do I proceed? So at this point, three things were running amok in my head. Number one, should I extend the incision and just deliver it manually? Number two, create a fresh scleral tunnel on the superior quadrant and then deliver manually? Or should I use a IOL scaffold technique in this patient? Well, I decided to go in with the third option, for the simple reason that there was only one fragment which was present, and the visualization was still going to be good because the other part of the antechamber was clear. Of course, there was a lot of loose lens matter in the capsular bag and the antechamber, which was expressed out with the OVD. And with the OVD also, I displaced the nucleus towards my left side so that I can visualize the rhexis margin very clearly. So I have created space in the ciliary sulcus that's above the anterocapsule and below the iris by using sodium hyaluronate. And now I'm going to try to place the haptics of my multipiece lens into the sulcus. And as luck would have it, the haptic directly finds its way through the posterior capsular tear itself. So I realized it quickly enough. Although the visualization was not great, I stop and then I'm trying to negotiate the haptic using a dialer out of the posterior capsular tear. The haptic would be maneuvered and placed on the surface of the iris. Using a microforceps, I'm grasping the haptic and then ensuring that it lands above the anterocapsule and below the iris. So one haptic has gone into the sulcus above the anterocapsule. The optic is then dialed below the iris level. One haptic is still kept over the iris. Now we have the lens blocking the entire posterior capsule and the hard nucleus is in the antechamber. So we're in a situation where the lens is going to give us ample support and barrier effect so that none of the smaller fragments are going to drop down. OVD is placed into the antechamber because it's important to be mindful that the cataract is extremely dense and corneal endothelium might take a hit. So as I'm emulsifying the nucleus, I want to be as slow as possible. I don't want the fragment to leave my phaco tip. It needs to be just sticking around and jumping around it as the nuclear fragment is getting smaller. Of course, a few of the outer layers of the nucleus are jumping around, but eventually the amount of turbulence is significantly less and the fragment could be emulsified slowly and steadily. Patient is complaining of a little bit of a discomfort, so I want to augment the anesthesia by giving 1.5 ml of posterior subtenous lidocaine in the subtenous space. Now, before I maneuver the intraocular lens into the right position, I want to remove the OVD which has gone behind the posterior capsule into the vitreous cavity. So here I go in with my cutter through the peripheral posterior tear. Mind you, even at this stage, the tear is not enlarged and I'm going to remove all the OVD which is being pumped into the vitreous cavity. After a couple of minutes, the vitrector is withdrawn and I'm going in with my bimanual aspiration cannula to see if I can clear off this muck on the posterior capsule. To my bad luck, the posterior capsule was looking fibrosed and these opacities in the posterior capsule were unlikely to be cleared. The haptic which was on the surface of the iris is then maneuvered into the ciliary sulcus. So now we have both the haptics in the sulcus above the anterocapsule and the optic is also above the level of the anterocapsule. So in this case, I've already decided that I'm going to keep the lens in the sulcus and achieve an optic capture. But the posterior capsule opacity is bothering me a little bit. So I'm wondering at this stage, should I clear it off? Now, since I've decided that I'm going to place the lens in the sulcus and achieve an optic capture, I thought I'll sacrifice this part of the posterior capsule so that the visual axis remains clear from day one. So I'm going in with my cutter and then cutting off the central capsule, trying to create a sort of a posterior capsule rhexis in the central area. So we have a peripheral tear and also a large central defect which is being intentionally created so that the visual axis remains clear. So once the posterior capsulotomy is done, now is the time to achieve optic capture. So as I'm retracting the iris and seeing the left hand side of the optic is already behind the capsular rhexis. So I go in with my dialer and try to tap the right half of the optic behind the rhexis margin. So eventually it goes behind and now we have a perfect optic capture. Just want to retract the iris and see that the haptic is below the level of the rhexis and the haptic is of course in front of the rhexis. So just confirm this on either ends. Time to remove the OVD and the wounds are hydrated. That's it, the case is done, and this is the fourth day where we have taken images of a dilated pupil so that we just want to ensure that the lens is well centered and just to know what is the size of the posterior capsular rhexis.
I think you can have a discussion on this case. And
Yes.
the second case I'll share later.
Yeah, brilliant, Deepak, as always. It's wonderful. Too much of heroism in just one case. Doing the first thing and using the presence of mind of the three options which you gave, and using the IOL so well it's a very important step to be taken. And unfortunately, the loop ended into the vitreous and into the tear. But despite that, you got it out. But
that point I wanted to highlight because these are things which are not discussed in the meetings. So usually you say it is so. What do you say? It's everything looks so easy, it never always goes behind the in front of the anterocapsule. It has a great tendency to go behind the posterior capsule. So I have many of my friends dropping the lens as well and trying to do this. So try to be conscious of that fact, mindful of that fact, and be very careful. So when you have got only one fragment, as was in this case, it's much more easier to use the IOL scaffold technique rather than having the entire nucleus there. If you have multiple fragments or large nucleus, the visualization is not so great. You don't know where the haptic is going on, and you don't know the size of the PCR as well. So you don't know where the haptic is going down. You don't know the size of the PCR. You have a higher risk of pushing the lens into the vitreous as well. So IOL scaffold, take it with a pinch of salt. Use it judiciously, not in every case. Okay. So probably in the next case, I'll show how not to use an IOL scaffold technique.
Yeah, so two things. Of course, the scaffold was a very important phenomena. And also the vitreous wasn't liquid vitreous. It was not walking out. The eye wasn't moving. Even though you were in topical, the patient was fairly cooperative. And which is why I was trying to say in the beginning, when in doubt, you think the patient is uncooperative, it's a tough cataract, no harm to your ego if you inject a peribulbar or a subtenon or whatever that you're comfortable with. Let the eye be anesthetized, your nerves will be cool. Because now if you're in trouble like this, and if the patient is not cooperative and is moving the eyes, and remember, blood droplets will start coming in from nowhere because the patient's pressure is also going up. And the moment the vitreous gets stained, you can get into trouble. Of course, Deepak very nicely gave us subtenon to reduce the pain. But don't be afraid if in a case, if you have to be prepared that you might land into trouble, to give a peribulbar. That's one thing that I would say always. And he was very good with the cutter. He was a little more greedy than what an average surgeon, because he's a very good surgeon, to go ahead with a vitrector and cut the posterior capsule so that you go ahead and create a nice circular opening, which would have been a lot more easier from a posterior segment point of view had you gone behind. That Shail would say that, making a circular opening. But multiple heroic procedures which Deepak did, I think, very nice, greatly presented, and having the courage to present that. What mistakes, and as you said rightly, the loop tends to walk in. When you don't want it, it walks into the vitreous. And it doesn't go just above the posterior capsule. And because of so much of muck around, you lost the sense of depth. You're not sure where the loop is going. Quite often, you are not able to judge and gauge that. So you had the other loop which was outside at that point. That is a great saving factor. You don't want to put the second loop inside. You could also do the levitation from behind in case the lens is sinking. One point that I've learned is very easy with a 30 gauge needle. With the other hand, just push it up and it comes off very well. It's not difficult. Just posterior levitation of the lens if it's starting to fall in behind. Just go 3.5 millimeter behind the limbus, push it up, adjust it just in front of the anterior capsule, and then proceed with the case. I guess this is from what I would have to say. Shail, would you like to say anything?
I think there's not much anyone can say with Dr. Deepak Megur's videos. Excellent teaching points. I have a slightly different view on nucleus and PCR. So I have 3-4 cases. We have 3-4 cases where more than 3/4 of the nucleus is in the bag, and we've identified a PCR like Dr. Megur has showed. And I think the major reason why the nucleus drops is when it gets wrapped by vitreous. That's something that we need to keep in mind. So there's the easiest way you can avoid the nucleus from dropping is to tackle the vitreous at the earliest point when you see it. So I would have probably gone in with a pars plana, having noticed that PCR, done a pars plana vitrectomy, try and convert that irregular tear slightly more into a stronger margin, and then go ahead with in the back phycoemulsification rather than doing a scaffold and things, because I find scaffold not only challenging, quite often very unpredictable also. And if by chance you somewhere find that the anterior capsule is split somewhere or something, then it becomes extremely messy. And if it drops, the safest technique is the bye-bye technique. Let it drop. That's the best technique to follow. That patient will have a much better long-term outcome. And that's something like we learned in the first case, that is swallowing our ego, that because we feel we must make sure that the cataract is out, we shouldn't compromise the long-term outcome for the patient. So if you feel if it's going to drop, then just let it drop, do the vitrectomy, do the IA 3-piece capture, and let the VR surgeon take over.
Thanks, Shail. Dr. Lani, sir, any comments that you would like to have?
I think what Shail told is very true. Say basically, but what Deepak did is also, I think, he has done excellently managed this case. It was a very difficult case. It is not an heroic. He managed it very scientifically with a very cool mind. And I think even the central PCCC, what he did was actually his that time intelligence that the second day patient should be good. So I appreciate Deepak. You managed very well. And yes, for every case, there are two schools of thought. But whatever you have done, it is the experience and also the you can say the nerves that you managed.
Thank you. Thank you, sir. Deepak, go ahead with the second case, please. Deepak, you are on.
Yeah, we can't hear you, Dr.
Yeah.
Deepak. No, we still can't hear you.
On mute.
I think audio, in that audio, you may have to change the setting because.
Am I audible now?
Yes.
Yes.
Okay, fine.
You are audible.
Okay, this is another very dense cataract, and
So I have this free fragment which is pulled out of the bag and is being emulsified. At this moment, I get a sense that something is wrong. This nuclear fragment is appearing slightly deeper. Let me check, I thought. I came out, injected OVD, and well, I can see that this fragment is definitely at a lower level. I use my Sinski just to feel it, and it seems that my worst fears are coming true. I'm looking for any visible posterior capsular tear, although the posterior capsular tear could not be made out, but there are all the signs which are definitely suggestive of an underlying posterior capsular tear, and if that is true.
so I want to pause the video now and take the opinion of all of you. Now, only one pie is there, 2/3 of the nucleus, or maybe 75% of the nucleus is still there. It is brown cataract. At this stage, I'm just having a suspicion. I'm sitting temporally. I made a temporal incision here. I'm doing phaco. I feel that because this fragment is slightly at a lower level, I feel there's something wrong here. And at this stage, how do you proceed now? Can any one of you just come in and tell?
Yes. Yes, Deepak. First, of course, you almost have to take it for granted that there is vitreous. The moment you have doubt, you may not have. That's a bonus that you may have. So take it for granted that you have vitreous. I would dislocate the nucleus, as I said, for the posterior levitation. If I would dislocate the nucleus above the anterior capsule, go with a slow phaco and try and do my phaco with, of course, your Cohevisc and whatever that is protecting you from the vitreous. Shail, what would you do?
On a slightly lighter, the first thing that I would do is just make a sign to my assistant, make a phone call in the retina OPD. The retina surgeon is probably going to have to come in very soon and get the retina vitrectomy machine ready. But yeah, this is a nightmare, having 3/4 of this brown nucleus and a possible PCR. I think everyone on that day will have another thing to do for this case.
Okay, let me just go through it now, just to save some time. Let us see. So, what are the things
True,
that are going in?
then I may be dealing with an impending nucleus drop. So I'm pushing dispersive OVD under the nuclear fragment. I'm just trying to figure out the extent of the PC tear, and I'm trying to maneuver the lens fragment out of the bag. In this process, the thin lens fiber which was connecting the two heminucleus, which I had not noticed initially, just snapped. And now I could sense that the smaller fragment has gone still posterior. Well, it is not looking good at all now. The nuclear fragment looks like it is descending down, and at this moment I'm thinking, should I close the case and let my retinal colleague deal with this later? In fact, I stop everything and thinking for about a minute on how to go about. And then I decide to go ahead and remove at least the anterior heminucleus and then see how things go. So I'm pushing dispersive OVD under the nuclear fragment. Now, since the heminucleus is quite large and bulky, I decide to make a fresh scleral tunnel incision in the superior quadrant. Mind you, I was sitting temporarily for the phacoemulsification. So I shift superiorly, give a subconch lignocaine, raise a small bleb, then make a conjunctival flap, and then using a blunt cannula, inject 1 ml of lignocaine in the posterior subtenon space. Augmenting anesthesia is critical, as I know that this surgery can take some time now. A scleral groove is created, and using a crescent knife, a sclerocorneal tunnel is created. The tunnel is at a slightly deeper plane when compared to this side port incision which was originally created for the phaco procedure. OVD inside the tunnel demonstrates the nice biconcave structure. The internal entry is done with a sharp keratome and the sclerocorneal tunnel is extended on either side. As soon as the antechamber is entered, there is a momentary shallowing of the anterior chamber. As a result of this, the nuclear fragments have also moved anteriorly. This was a blessing in disguise. Dispersive OVD is injected under the fragments. One fragment has floated up into the anterior chamber. OVD is injected above the fragment and under the corneal endothelium. Using the sandwich technique, the heminucleus is guided out. The second heminucleus has subsequently moved up anteriorly. And again, the same process of injecting dispersive OVD under it is done and it is maneuvered into the antechamber. Using dispersive OVD under the heminucleus is critical because it pushes away any vitreous which is surrounding it and also acts like a barrier. The heminucleus then from the antechamber is expressed out quite easily. OVD is injected into the eye and then I turn on the retinal illumination mode. It is evident that there is a huge posterior capsular tear. In fact, I am not able to see any edge of the posterior capsular tear now. The anterior capsular margin is quite clear all around and there is some cortex yet to be removed. But before attending to the cortex, I need to perform anterior vitrectomy first. I create a side port for the cutter. I'm using the original phaco incision for irrigation. I'm holding the cannula in a slanted way to block the big incisions so to minimize any wound leak. Well, this is just a workaround to avoid another side port for the irrigation. So I begin my anterior vitrectomy process and in a couple of minutes the anterior vitrectomy is complete and now is the time to remove the cortex. It's important to remember that any remaining epinucleus or cortex has to be dealt with only after the prolapsed vitreous is taken care of. As the cortex is being aspirated, I can see the edges of the torn posterior capsule. Before implanting the IOL, I'm using diluted triamcinolone acetate to check for any remaining vitreous fibril. Well, there are few of them which are then taken care of. I'm using sodium hyaluronate to create some space between the iris and the anterior capsule. A multi-piece hydrophobic IOL is gently slid above the anterior capsule and the proximal haptic is dialed in so that the entire lens is presently above the anterior capsule in the ciliary sulcus. I ensure this by retracting the iris back and visualizing the haptics above the anterior capsule. Using the retractor, I go behind the lens to remove some of the OVD which has gone behind into the vitreous cavity. Once all the OVD is removed, time to achieve the optic capture. The optic of the lens is gently pushed back posteriorly until we see this ovalization of the rhexis margin, which confirms optic capture wherein the haptics are in the sulcus and the optic is trapped behind the rhexis margin. The side ports are hydrated. I'm using diluted triamcinolone acetate to check for any remaining vitreous fibril. The superior scleral tunnel incision is sutured with a single 10-0 nylon suture to take care of the pre-existing against the rule astigmatism and also to avoid any postoperative hypotony which we see commonly in eyes which have undergone antivitrectomy. The conjunctiva is then closed with atovitreal suture. It's extremely important for me to finish well. I really want to see the eye look really good at the end. So no matter how long the surgery has been, so finishing well is very important. So once done, this is the next day picture. The patient cornea is clear, the pupil is round, the patient.
I think that was one way of managing, I guess. So never, I won't hesitate to convert in the slightest doubt whenever it is. I think it is especially people who are having single practitioners who don't have a backup retina surgeon at your place. It would definitely be, if you're good at doing SICS, it really is a great savior. So one point which I would like to highlight here is never go and chase the nucleus here in these situations. It is never to be done. Just put viscoelastic behind the nucleus. If it floats up, fine. Otherwise, you just leave it. That would be the thing. If you just flow, if you just put it dispersively behind the lens, and if it comes up, it's fine, well and good.
Absolutely. Deepak, are you there?
Yeah, yes.
Yeah, okay, yeah. No, absolutely brilliant, brilliant presentation. No hesitation, ego doesn't matter. Patient will not remember anything else except that they can see after 6 months. That's all that matters. Nothing else matters. An extra suture does not matter. A little vision here and there, a small number, a small cylinder, nothing matters. And all the tissues are quite surgeon friendly. So they are good if you respect them. And a hallmark of a good plastic surgeon, you know how great work orthopedic surgeons do inside, but when they come out, look at the skin scar which is there. It is ghastly. So what Deepak said is something very, very correct, that as a surgeon, he likes to see that everything looks very nice and you get a feel-good feeling. The pupil is nice, reacting well, the conjunctiva is closed very well. One more thing again that I would say that, the nucleus part came out quite comfortably as the chamber shallowed. But one more thing I'll repeat is, again, a second hand with a 30 gauge, you could very easily, which is not coming off, just very easily you can push it up into the anterior chamber and it comes out and stays there. Unless it's a bad liquid vitreous and it falls behind. So as rest, don't chase it from the front, push it, get it up, put in your viscoelastic and see that you get on with the whole case smoothly. I guess, and knowing your basic fundamentals on vitrectomy is essential, using your trimethoprim alone. You don't have to depend on a retina surgeon at that point. And then if you don't have a retina surgeon present, let the nucleus fall. That's not the end of the story. That's less trouble for you in the long run. You are sharing responsibility and somebody else can do a great job also. Anything else that, Shail, you would like to say? Dr. Lane, would you like to say anything?
No, sir, I think all the points have been covered so nicely by Dr. Megur, and his videos are always so stunning. Yeah.
I think Deepak's video was only the eye opener. So nothing I think we should comment. He has done very well. And definitely whenever there is a problem, we should go for the SICS. And I always feel that when the patient is having the grade 4 nucleus black, in such situation, instead of going for PECO, go for SICS, and your life is also it can increase by 1 day once we will not do PECO. So I always in black nucleus or in Niagara or in the rubra, I do SICS today also. Patient, whatever patient may be, how much VIP patient may be, I operate with the SICS, and second day I'm happy.
I think I just want to recall that Dr. Vasavada sir used to tell in one of the talks I heard him, don't look at the watch, look at the calendar. Whenever a complication happens, look at the calendar. So don't bother about 10 minutes, 15 minutes more, Ultimately, you have to do the best possible job for the patient at that time. What happens, you mentally are stressed, another 5-6 cases are waiting. This is the first or second case. Those things should not be a concern at all. You should be allotting maybe the whole day for this patient, let me do the best job. So this mental clarity has to be there whenever we have these complications.
So when patient asks me, how much time will the surgery take? My answer is very clear. First, I can't afford a watch, so I don't wear a watch. And 2, there is no watch in my OT. So time is of zero significance. We are not running a marathon. So who comes first out of the theater is not the winner. Who comes out successful is the winner. So the mindset of an anterior segment surgery is 6 minutes, 7 minutes, 8 minutes. How fast can we finish? I was quite surprised when one talk was there on how quickly somebody can do the surgery. The turnover time of a patient. I guess that's where trouble can start. If you're mentally prepared, just be prepared. It can take for whatever. 2 surgeries can be postponed to another day. But here, you need to cool down and get your stuff done. I guess a brilliant presentation. Manish, would you like to say anything? Would you have any comments?
I think it was the documentation is so brilliantly done, and amazing videos, Dr. Deepak. Thank you so much. And I think the very, very practical thing to do with such a hard nucleus to attempt to phaco the endothelium would take a lot of beating, and plus the possibility of the thing dropping up. So what would you thought of, was absolutely brilliant. And seeing the patient 612 uncorrected the next day with a clear cornea and such a quiet eye, I guess is icing on the cake. So amazingly done case.
Yes, absolutely. So we, like all good things, have to come to an end. I must say that thank you so much, Shail and Deepak, for being here and being so lucid about your talks, and brilliant presentation. Each step being explained, what to do, what not to do, how can we avoid it, what are the options, how to handle each part. Friends, this is just part one of posterior capsule, because posterior capsule is like a Bible, like Grey's Anatomy. There's a lot more to be said on that. If you're punched in the beginning, what will you do at various steps? So we have had this, but we'll have more cases coming up to discuss more in the next eye crash investigation series that we have. Hope this has been a great learning experience, and it brings a lot of wisdom to be shared amongst all of us, because if one of them has gone through it, we all will go through it. And how to cool your nerves at that point in time and to handle that is a very important thing. Manish, over to you. Dr. Lane, sir, any comment that you would like to make?
Lane, sir, are you there? A final comment from you?
I'm there. I'm very much thankful to the, can say the Raunak, even the Deepak and Shail. They have presented very well cases, and also it was a very good learning experience. Thank you very much. And
Thank
also
you,
our president and secretary, who are taking so much pain to teach the all the colleagues in ophthalmology, so that they should not have some problems in their practice. Thank you.
Thank you so much, sir. Once again, on behalf of BOA, a big thank you to our speakers, Dr. Raunak Solanki, Dr. Shail Vasavada, and Dr. Deepak Megur for their presentations. And we look forward to having more sessions of eye crash. Like sir said, PCR itself will be taken up again, and many more interesting topics. And we are glad that we finished in time today, so that your dinner is not delayed too much. We have some other interesting programs lined up. We look forward to seeing you soon with those.
Manish, what about the picnic that you are talking about?
Yeah. So we are going for a picnic to Khopoli, to the Novotel Imagica on 19th and 20th, and we have a fairly good number of people coming. We're going to be having a clinical meeting also, and we are trying to accommodate as many people as we can. So if you've still not filled in, then and do fill up the form and contact me or Dr. Himanshu. We'll try and accommodate you. It'll be a mix of fun along with some clinical learning. And we are also lined up a big CME on glaucoma on the 3rd of September. So block that date also.
Yes, so the 3rd September is a physical meet at Sea Princess. It should be a very nice meeting, and everybody should enjoy it. And Shail, Deepak, if you by any chance are in Bombay, we would like to be inviting you as guests. It will be a great entertainment. It's a nice place, and Maharashtra and Bombay is very beautiful during monsoon. And the rain gods are really very thankful, pure lush green. And the Imagica place is an absolute imagination, mind-boggling. You're welcome to join us. We'll be more than happy to have you here.
Absolutely. Please connect with me or sir, and we'll be happy. Whoever is tuned in and has not yet registered and wants to do touch base with us, we will try and accommodate as many people as we can. Thank you so much. I think we've had a very, very good meeting, and we would like to call it a day. Have a pleasant evening, ladies and gentlemen.
Thank you so much.
Thank you. Thank you.
Thank you, everyone, for being sport and participating.
Thank you.